To start the process session, please. So this session is about process embolization, improving your outcome. It's my honor and pleasure to moderate this session together with Professor Javar Gulzarian, Professor Hisham Kopeter, Professor Ahmed Said. And we start by the first speaker, Professor Ahmed Said, talking about catalog for prostate vascular anatomy and variants. Please, Dr. Ahmed.
Assalamu alaikum. Good morning, everybody. First of all, I would like to thank the organizing committee to invite me to be here with you today. Bismillah ar-Rahman ar-Rahim. Prostatic artery embolization is a technical challenging procedure and need in-depth knowledge of the complex and variable anatomy of the pelvic vessels. Successful outcomes depends on accurate identification of the prostatic artery and its possible anastomosis to improve the technical success and prevent the non-target embolization. It is not as easy as it looks, but it could be easy with proper technique, knowledge, and the planning of the technique itself. The anatomy of the prostatic artery started from the aorta and ends by the terminal branches of the prostatic artery within the prostate. We'll discuss it in 3 levels: the aortoiliac anatomy, the internal iliac artery, its branches and bifurcation, and of course the prostatic artery itself, its variant, anastomosis, and the branches. There are many variations, the collaterals and anastomosis between same side, other side, external iliac artery, and the proximal branches from the aorta. Regarding the aortoiliac anatomy, the level of the bifurcation usually at L4, but maybe higher. The aortoiliac and common iliac angles around 40 to 85%. When it becomes acute, it becomes more difficult technique. And of course, the atherosclerotic changes, including the tortuosity, ectasia, and thrombosis. All these factors will affect the procedure approach, degree of difficulty, procedure time, and radiation exposure. The internal iliac artery, the most common types, give posterior division and anterior division. In every angiogram, we should identify 4 major vessels. The largest is the superior gluteal from the posterior division, and then the inferior gluteal from the anterior division. The internal pudendal artery, which goes inferior outside the pelvis, then enters the pelvis again, giving the G-shaped characteristic, G-shaped appearance. And the more horizontal, rather horizontal branches, the obturator gives the characteristic trifurcation. Then we go anteriorly to 2 smaller branches arising from the anterior division. The first one is the superior vesicle, followed by the prostatic artery, which is run parallel to the internal pudendal, and most tortuous, giving the coarse screw appearance. Number 3, the prostatic artery itself. The anatomy is variable from man to man and from side to side in the same patient. 90% arises from the anterior division of the internal iliac, usually single artery for each side, but about 20% of cases receive dual arterial supply for the same side. The mean diameter is 1.6 to 2 millimeter, but in large volume of the prostate, it may reach to up to 2.6. Then it is directed inferior and medially along the tortuous course to reach the prostate, giving the central anterolateral branch, which is named artery of the adenoma, and the capsular posterolateral branches, which may pass to the rectum and the anal canal. Intra and extra prostatic anastomosis are common. This is the typical prostatic blush, which is anterior, inferior, and dense, and should be differentiated from the vesical blush, which is superior, and the rectal blush, which is posterior and concave. According to San Paulo classification, Carnival et al., the prostatic artery is classified into 5 types. Type 1, arising common trunk with the superior vesical artery, which this trunk may be short or long. It is considered the difficult type of the prostatic artery due to the acute angles. Type 2, arising inferior to the superior vesical artery from the anterior trunk. Type 3, arising from the obturator artery. And type 4, arising from the internal pudendal artery. In this case, let's revise the anatomy. This is the superior gluteal, the first one, the inferior gluteal, then the internal pudendal. In this case, the obturator arising from the posterior division. This is the easy access for the prostatic artery, but carry a risk of non-target embolization to the rectum and the internal pudendal. At the middle rectal artery arises from the internal pudendal with the prosthetic in much cases of this. Type 5, I called it the others. The others, it means it arises from others branches, as from the posterior division, from the accessory pudendal artery, and from the apparent obturator artery. In this case, it arises from the posterior division. Here it arises from the accessory pudendal, which run parallel to the internal pudendal, and this is considered one of the difficult cases. Sometimes when do angiogram of the internal iliac artery, we noticed no obturator and no prosthetic artery. In this case, there is a superior gluteal, inferior gluteal, internal pudendal, and superior vesicle. And it is called the empty pelvic sign. We go to the external carotid, and here we can see the common trunk giving the inferior epigastric artery runs superiorly, and the obturator artery enters the pelvis again, and giving its trifurcation, characteristic trifurcation, and giving a small branch, which is the prosthetic blush. The apparent obturator is called the corona mortis, as it crosses over the superior pubic ramus, and here it is more liable to bleed with fractures or during operations. In 20% of the cases, double arterial supply the same side can occur. In this case, type 1 is seen arising with the superior vesicle, and type 4 from the internal pudendal. Anastomosis with prosthetic artery occurs up to 60%. Arterial anastomosis are the main pathway for non-target embolization. Prosthetic arteries are commonly communicate with vesicle, rectal, penile, and the gluteal branches. Careful angiography, cone beam CT, and super selective embolization are essential to ensure safety and the optimum outcome. In this case, there is anastomosis with the penile artery, and we go distal to the prostate and insert a coil, then embolize safely. In this case, the prosthetic gives rise to middle rectal anastomosis branch and carry risk with non-target embolization and should be coiled proximally. And here, contralateral intraprostatic anastomosis, as one prosthetic artery can supply the whole prostate, especially in cases of previous surgery or if there is ostial stenosis to the origin of the prosthetic, as in this case. This is a general report for the prosthetic artery anatomy. It is applied for the CT, but we can apply to any angiography. We'll discuss the three levels I mentioned: the atherosclerotic at the level of the aorta, the aortic bifurcation, the angle, and the level. Then we start every side separately. The right iliac system, its division. Then the right prosthetic artery, one prosthetic artery, type 2. Then the possible anastomosis and the caliper. And repeat to the left side. To sum up, how to identify the prosthetic artery simply: doing CT angiography in selected cases, doing oblique view during angiography, identify the four major branches: superior gluteal, inferior gluteal, obturator, and internal pudendal. Then go anteriorly to two small branches. The first is the superior vesicle. The second is the prosthetic artery, which is parallel to the pudendal and having the most tortuous course with characteristic prosthetic blush, central, anterior, and dense, and should be differentiated from the vesicle and the rectal blushes, and look almost for possible anastomosis with the vesicle, rectum, and the penile, and almost all you should use the cone beam CT. And so the prosthetic anatomy is the key for successful prosthetic artery embolization. Understanding the standard classification variations and anastomosis can help to reduce procedure time and radiation exposure, minimize non-target embolization, improve technical success, and reduce the incidence of revascularization and recurrence. Thank you.
Okay, thank you so much for the excellent talk. I'm going to introduce the next speaker.